I'm Bob Brown, the president of Boston University, and I want to thank Jim Brett of the New England Council for organizing and hosting this panel today, which I don't think could be more timely. I'm also grateful to the Council for their tireless advocacy of federal research funding, which is so critical to the greater Boston community with our thriving life science research, great teaching hospitals, and research universities. So thank you for all of your efforts. I also want to recognize the Massachusetts Commissioner of Public Health, Cheryl Bartlett, as well as representatives from the Boston Public Health Commission and Massport who are with us today. These individuals serve on the front lines of preparedness planning in Massachusetts. And I want to thank you for the work in this critical area and for helping prevent and control infectious disease in our state. And it's a pleasure to welcome everyone to Boston University and to the National Emerging Infectious Diseases Laboratory, the NEIDL as we call it. I know that you appreciate that you are in one of the most unique research facilities in the world, designed specifically for studying emerging infectious diseases, such as the one that we're going to talk about today, in a state-of-the-art facility. In fact, you have a window there that you can view one of the training rooms firsthand. It's not an active laboratory, for those of you who wonder. It's a training room. This facility has been in planning, construction, and litigation for over a decade. It is preparing to become fully operational in the coming year as a major research laboratory, and it could not be more timely. When I think about it, and I do think about it a lot, I am both optimistic and at the same time sad. Optimistic because it gives us the opportunity for Boston University and all of our collaborators and other institutions to play an important role in understanding and finding cures to deadly emerging infectious diseases like Ebola. There is a sadness, though, and the sadness is that it's taken a decade to get to this point in time, and that the public awareness of the importance of this kind of research really has only been raised by a horrific epidemic, Ebola epidemic in West Africa. When I think about those things, I think about what will happen in the coming years. And I also think about Richard Preston's book, Hot Zone. I'm sure a number of people in this room have read it. Written 2 decades ago about. He describes the diseases caused by viral viruses and the threat of an epidemic, although at that time occurrences of Ebola and other hemorrhagic fevers were limited mainly to remote locations in Africa. They knew very little about those family of diseases when that book was written. Now we have an Ebola epidemic infecting at least 15,000 people with over 5,000 deaths, at least 5,000 deaths. And we still don't know a great deal about the disease and the other diseases in this family. Today you'll hear about, from experts about Ebola, the epidemic, and the public health effort that is underway, and how the city of Boston and other cities that could be affected would take account of that if a case walked into an emergency room in one of our hospitals, like Boston Medical Center. Hopefully this will never happen. But until science creates cures and vaccines, we will have to rely on symptomatic treatments and public health interventions as our best defense against these viruses. I know that the panel will be informative and timely, and I want to thank you again for being here.
Well, let me begin by thanking President Brown and the entire team here at Boston University. Not just for hosting us here at the NEIDL, but also for their assistance in putting together this very important program. In particular, I just want to give a little shout out to 2 of your hard-working staff people here, and that's Michelle Consalvo and Meredith Mooney, who did a terrific job in organizing here. You should be very proud of the work that they do, not just on this particular forum, but for Boston University. I'd also like to acknowledge the presence of our 2 chairs of Healthcare Committee of the New England Council. Laurel Sweeney of Phillips Healthcare is our chair, and our co-chair is Joe Alviani of Partners Healthcare, and I also want to thank them for their support. And in particular, a very special shout out to Heather Gasper for all the work that she did. We know that we love Joe Elviani from Partners, but it's Heather that does all of the work, and we want to acknowledge her in her hard work. I'd be remiss if I didn't acknowledge the presence of David O'Donnell, who staffs the Healthcare Committee on the New England Council and does a fabulous job in preparing today, so I just want to thank him. Before we turn to our distinguished panel, I just want to welcome a very special guest. She has a very tight schedule, and we were trying to fit the commissioner in today, and she has been gracious enough to come at the beginning here. So Cheryl Bartlett is the commissioner of the Massachusetts Department of Public Health, a position that she's held since June of 2013. She has extensive experience as a registered nurse and a hospital administrator, implementing health system changes through quality assessment and improvement practices. Over the past several months, her agency, and she's been a leader, has been at the forefront of preparedness at the state level as well as the local level to address any cases of the Ebola virus in our region, working hand in hand with our hospitals and our local public officials. So we're pleased that she could join us today and say a few words. Please join me in welcoming the Commissioner, Cheryl Bartlett.
Thank you, and good morning, and welcome to today's expert panel discussion on Ebola preparedness and response. I'd like to thank the New England Council for hosting this, and I think the title is a good one, The Truth About Ebola for New England, Fact versus Hype. It is a fact that Ebola is a scary disease, and the epidemics in Liberia, Sierra Leone, and Guinea are heartbreaking. It is also very unfortunate that 2 of my fellow nurses contracted Ebola while caring for a patient in Texas. Ebola has consumed the media and the public for months. Nonstop TV footage showing workers involved with Ebola patients wearing hazmat gear make it challenging for states in the U.S. to be appropriately prepared. The hype has forced preparedness planning to respond in ways that become impossible to implement or sustain. Here in Massachusetts, we began planning for the possibility of a patient with Ebola arriving at our healthcare doors before the World Health Organization even declared this an international concern. With teams of experts and professionals across the continuum of care, we have emphasized planning and supporting protocols that are based on fact and not on hype. We host multiple weekly and daily and multiple daily calls with thousands of people participating to keep our response up to date with the latest facts about what is happening both here and abroad. As the Public Health Commissioner, I am both pleased and proud of our efforts to create a coordinated, collaborative system that continues to evolve based on fact. I look forward to today's discussion as information is key to keeping us moving forward and to be ready to provide compassionate care for patients with Ebola here in our world-class health institutions. As a former hospital infection control nurse, I believe we can support our frontline workers with the proper personal protective equipment and training, working with our world-class reputation. I would especially like to acknowledge Dr. Paul Biddinger for his leadership and the support that he's provided for me and the department as we work together to be prepared to address Ebola here in Massachusetts. Thank you.
Thanks very much. So we're here today to talk about a topic that has dominated the headlines this fall, the Ebola outbreak and its spread in the United States. In fact, if you just read the daily newspaper today, the Globe, 2 major stories on Ebola. So it's a hot issue, and I can't think of a better time to be discussing it here. As the Ebola outbreak in West Africa continues, the threat of additional cases appearing in the United States persists. As you know, to date, there have been 4 confirmed cases in the United States. 1 patient has died, 2 have recovered, and a 4th is currently in isolation and receiving treatment in New York City. I can't think of a better venue than here at the NEIDL. This facility is designed to study diseases that pose a significant risk to public health and is one of only 2 university laboratories in our nation that will handle cases as extreme, as biosafety level 4, a designation used for high-risk pathogens such as Ebola. So we're very fortunate to have this facility in this city. Needless to say, as already been mentioned, we're fortunate today to have 4 of New England's region's top medical and public health experts join us for what I know will be a very fascinating and informative discussion. Our panelists have been on the front lines and quite literally of treating Ebola and preparing for possible cases here in our region. We hope that the panel can address in the next an hour and 50 minutes, the panel will address various elements of U.S. and international responses to the ongoing outbreak, as well as other issues, including health system preparedness, protocol for screening and containment, travel and transport issues, research and development of Ebola treatments and vaccines, the appropriate use of experimental drugs, whether U.S. programs have appropriately improved preparedness for emerging infectious diseases, and then what measures the business community can take to assist with these efforts. So hopefully we can get all that done in an hour and 50 minutes. Wouldn't that be great? But if anyone can do it, our panelists can do it. And let me just begin by acknowledging the presence of Dr. Ron Corley. He's the director of the NEIDL and a professor of microbiology. And he's an expert in Ebola and other infectious diseases. He joined Boston University, I believe, in 1994 as the chair of the Department of Microbiology at the medical campus. October of 2014, he was elevated to become the director of the National Emerging Infectious Disease Laboratory, and where he served for the last 7 years. Dr. NEIDL Bhadelia is the director of infection control at NEIDL here, where her specialty is infectious infection control issues related to emerging pathogens and highly communicable infectious diseases. She's the director of the Medical Response Program for NEIDL and provides input into BU's research occupational health policies related to infectious diseases. Most recently, she's been part of the World Health Organization Operation Sierra Leone to combat the Ebola outbreak in West Africa in August of 2014, and I believe she is returning to Sierra Leone later this month. Dr. Paul Biddinger is the Assistant Director of the Harvard School of Public Health Center for Public Health Preparedness. He's also the Director of the Medical Director for the Emergency Preparedness at Massachusetts General Hospital here in Boston. He's a practicing emergency physician. He chairs the Massachusetts Medical Society's Committee on Preparedness at Harvard School of Public Health. He leads a team of professionals and researchers who focus on developing exercises and associated tools for both training and evaluation of public health, emergency preparedness, and response. He is also the medical officer with the United States Department of Health and Human Service National Disaster Medical System Team. Dr. Jamie Childs is a senior research scientist and lecturer in epidemiology, specializing in microbial diseases at the Yale School of Public Health. He's a zoonotic disease specialist at the Yale School of Public Health. He's worked on previous outbreaks of Ebola virus. Prior to joining Yale in 2004, Dr. Childs worked at the Center for Disease Control and Prevention and spent 4 weeks on the ground in Zaire, now the Democratic Republic of Congo, in 1995, investigating the Ebola outbreak that killed some 280 people of the 318 people infected. So I just want to thank all of these extraordinary and gifted individuals for joining us here today. And we have a few questions for them, and then maybe all of them can feel as though they can just break into any answer they want to give. We have time at the end for all of your questions. I know many of you already have indicated you'd like to ask some questions, but let me just start the conversation. Where this crisis began in West Africa, maybe Dr. Bhadelia, you were recently in Sierra Leone treating the Ebola patients. Maybe you can give us just a quick snapshot of what it was like there and what has happened since your visit's been there.
Great, thank you. As was mentioned, I was in Sierra Leone for about 12 days at an Ebola treatment unit in Kenema. And really the defining features of our experience there was this profound lack of human resources. You know, at that point, I think that we were strapped for physical resources as well. 4 physicians to about 100 patients. And towards the end of my time there, we were turning patients away at the door of the Ebola treatment unit. And since then, you're seeing a few things that have remained constant. What plagued us at the beginning of the summer was a lack of good data. Reported data is based on collected data. And if there's a lack of human resources to collect the right data, you can't really depend on the data that's being published. And that's what we've really seen. I think even when we're hearing these great reports about the decrease in caseloads in Monrovia, there's a little bit of caution in terms of what that means. Is that because patients are not coming to care? Is it because patients are not being diagnosed? Or is it because there aren't enough beds to put these patients there so they can be counted? I think that all those things are sort of steady things that have remained constant since the summer. The other thing that's remained pretty constant, I'm actually leaving later today to Sierra Leone, is basically the lack of human resources. You know, the epidemic in Sierra Leone has shifted from Kenema, which is the epicenter when I was there, and now a lot of the cases are in Freetown and Bombali and Port Loko. And the calls that I'm hearing from Port Loko yesterday or 2 days ago was the same thing. Ministry of Health has an Ebola treatment unit. There are over 100 patients in there. The capacity is only 60 people. Oh, and by the way, there are no physicians there. Can you come as soon as you can? And that's remained pretty constant. So the physical resources are there. As you know, the U.S. has sent military presence there. And we have some physical resources. We have additional monetary commitments that have been made since the summer. The thing to keep in mind, though, is that it takes time from the minute that the money is committed for it to make it to the ground. And that's certainly a lag that's felt very acutely in the field. And even of the resources that are committed, you know, the WHO has given a conservative measure that if you had 10,000 cases, you need about 7,000 beds for treatment to really stymie this epidemic, to really change the course of this epidemic. There's only 4,300 beds planned. That's not built, planned. So I think we have a lot of work ahead of us. The other thing that's really important to note is that we're really seeing the majority of the morbidity and mortality now is not Ebola. It's actually other preventable diseases. You know, all of these countries where had poor infrastructure to begin with, very low human healthcare worker to population ratio, and due to migration, illness, or death, they've decreased their ranks tremendously from the beginning of this epidemic. So people are actually dying of malaria. Childhood vaccinations are down. Pregnant women with high-risk pregnancies have nowhere to go because no one wants to take them in case their abortion is from Ebola and not from, you know, a complication of pregnancy. So it remains, it may seem all dire. I think we have made improvements. You know, one thing that I will mention is that we are finding stuff about this disease. One thing that we are finding out about this disease is the fact that many people survive it. You know, traditionally with epidemics, when you see new pathogens, you have a biased view because only the sickest come to care, and those are the ones that are tested, and hence the mortality appears very high. And what we're noticing in this epidemic is that the survival rate increases the earlier you present to care. And in our Ebola treatment unit, for those who presented to care in time, the mortality rate was below 40%. And that's with 4 doctors to 100 patients. Imagine what we can do with more people to help. So certainly I think that's a positive aspect. So I'll end there. And
what was the success rate again?
The 60% survival rate for those who made it in time. I think overall it was closer to 50 because a lot of people didn't present to care on time because people are in the community. And, you know, we need hands to bring them into care. We need beds to take them in.
Anybody else want to weigh in on this?
Well, I think, you know, one of the questions is always going to be, how did we get to this point?
Well, I was going to ask you that, too. Was this something that was preventable?
Yeah, I mean, it's what it points out, and I think it's a really critically important thing, is that, you know, a lot of diseases like Ebola do crop up in kind of remote areas. But we've always known that if somehow one of these outbreaks goes undiagnosed and gets into cities, then it changes the dynamics of it. And as Nahid has already said, you know, one of the things in reporting means you have to do surveillance, and you have to have good surveillance programs. And those surveillance programs need to be not only for humans, but also to try to identify the animal reservoirs and understand the movement of diseases between animal reservoirs. And finally, diagnostics become absolutely critical in this, because if you can't do rapid diagnostics, then you can't identify the disease, and that's one of the reasons why the disease was missed for 3 months before someone finally realized what it was.
Do you want, Doctor?
I was just going to reiterate the point that more manpower is critical in these afflicted countries, and not just to man and staff hospitals, but to get out and find cases in remote areas and establish contact tracing, which is critical to control these sort of outbreaks. And the staffing of trained professionals who can go out and collect bodies and do the contact tracing. And remember, everyone who breaks with Ebola, you have another slew of contacts. There just aren't enough personnel. And this is one of the hardest things to establish. And it's an absolutely critical need for all these countries.
Dr. Childs, you were in Zaire in 1995. Talk about the comparison and the outbreak then compared to now. It seems to be much more aggressive here today than you were there. But
well, I'll compare it with the Ebola outbreak in Kikwit, Zaire, now the DRC. First of all, this is a multinational outbreak. And not only multinational, but it's affecting multiple states or provinces within each country. So we have them far.
yeah,
Pardon?
it's hard to.
Is this on? Oh, okay. I'll speak up.
Yeah.
Okay, I'll speak up. And anyway, what I was saying is it's a multinational outbreak, and in afflicted countries, you have multiple provinces or states which are have infected patients. It's already been mentioned that this outbreak has gotten into urban centers, which is unique. It wasn't any small town. It had between 300 and 400,000 individuals. But the crowding was far less severe. The other thing which is very important, and just to get the multinational level for a few more comments, is I don't know who's in charge. There have been persons in Liberia who are designated to be in charge, but this outbreak really calls for a coordinated response across multinational borders. And God knows if this gets into other countries, this becomes really a critical point. If you have many, many organizations involved in coordinating their own control, there does not appear to be an overarching general in charge. It's already been mentioned that the response to this outbreak was slow. In the previous 23 outbreaks of Ebola, the average time from which the case was first identified, that is confirmed, to response has been over 2 months. And this long delay in responding to this outbreak has definitely led to us being less capable of controlling the outbreak at an early interval. The response to these outbreaks, it's very important, and I mentioned this on a national level, but even at a local level, when we responded to the outbreak in Kikwit, it was very shortly, in a matter of a week since the case was diagnosed, that we had people on the ground. We had terrific coordination between the CDC, the MSF, and the WHO. Each had a clear line of responsibility, ranging from providing infrastructure and physicians to work on the wards. The MSF also provided water filters and clean water, so there was a coordinated and dedicated response. There were enough people on the ground that cases could be tracked, so it's a very different situation. But obviously the disease shares some similarities, although currently it looks like the outbreak may have fewer mortalities than what we saw in Kikwit. Oh, I'm sorry. Okay, I'm trying to speak up. I've got broken ribs, so so my lungs are slightly challenged. But in any case, the outbreak in Kikwit killed an estimated 300 plus people, of which 80 were healthcare workers. And we're seeing the same phenomenon in this outbreak. But in these countries, as we already heard, medical staff, trained medical staff are very low, very high percentage of patients per doctor, so that these are added burdens. And this is a brand new region for Ebola. So much of the infrastructure, which could be rapidly put in the field in Zaire, is just not there in these countries. New experience.
If I could just ask one more international question, Dr. Bhadelia. What role is the United States playing in West Africa? Are they playing a major role, or are they?
Well, we've, I think we could definitely do more. However, I think that we have led the charge in terms of we've sent our military down there, and there's mixed reviews in terms of whether that's a good idea or not. One can sort of talk about that. From my perspective, I think that the U.S. military will do a great job in setting down logistics. One of the problems was securing supply lines to ensure that the materials can get where they need to go. And the healthcare worker hospital that's being built in Monrovia, I think, will be a major asset to those in the field right now. We've made monetary commitment. The things that we're lagging behind some other countries, such as Cuba, they sent 200 doctors and nurses. We're still lagging behind on some of our medical commitments, and I think this is why the conversation about healthcare workers is so important. I think that the commercial field, the commercial sector, really needs to also be involved a lot more, and really needs to open up and make more financial commitments, given that these are actually pretty resource-rich countries that actually add to the international commercial trade. So that's where we're lacking. That's the part of the sector for the U.S. that's lacking.
Yeah. I know the Congress just passed this past month,
Yeah.
$6.2 billion.
Right. We've made the monetary, yeah.
Okay.
Can I just comment on that?
Sure.
It's also my understanding that the U.S. is building facilities, will provide some training, but other than the presence of people at CDC and so forth as experts who will go to man them, that the United States will not provide, other than that, the staff to man
Right.
these.
We have a lot of, I think that we've made commitments in terms of case finding, and there's a lot of CDC presence in that. We haven't made as much of a commitment for people who treat the actual patients.
If I could just shift gears just a little bit and talk about the spread of the disease here in the United States. And again, jump in. One of the questions that people tend to ask around this issue is what type of travel restrictions do you think would be appropriate and necessary in this type of situation? Maybe Dr. Biddinger?
Sure. Well, I think, like probably so many of the comments we're going to make today, evidence-based and science-based is really where we should be making our policy. And on travel restrictions, there's a lot of science there. There's a lot of science that says that a travel ban and overarching travel restrictions not only don't work at limiting the spread of disease, but they're even more harmful for the good that we need to do for the countries that are so affected. They're terribly damaging to those countries economically, and these are not economies that are strong and have a lot of robust backup anyway. But it also hurts the humanitarian response. And I think one of the things I've been most fearful of is we've seen some of the travel restrictions proposed for volunteer healthcare workers is exactly what NEIDL is speaking about, that we want people to feel comfortable and confident that they can both go and return from service in these countries where, again, that really is where the vast majority of infections are occurring. We want to know that we're supporting our healthcare staff. I definitely think that as we have a treatment hospital now for the unlikely but possible event that someone could become ill from exposure to Ebola over there, they can get medical care the same as they would hopefully with the United States. But those that don't get sick can come back, can be with their families, are not going to be locked in a room, and can monitor their health responsibly with public health officials. I think that's what we should be doing. I think it's very important we do identify who's traveling over, who comes back. We give them good education before and afterwards. We monitor health, and we provide extraordinarily robust resources to support those people who are willing to put themselves on the front lines, such as NEIDL. But I think what we need to do is not be political, frankly, in what we do, and we don't want to stigmatize those who are willing to help. And I think it's been unfortunately very, very polarizing. I think we should not be putting travel restrictions in place beyond what the evidence says is helpful in limiting the spread of disease.
Okay. Just following up on that, in the last couple of weeks we've heard the word quarantine used an awful lot, and we saw how it played out just recently with the nurse in Maine. And so who should be quarantined, and then why?
I'll start, but I'm sure many of us have several comments on this. I'd be remiss as a public health professional if I didn't define terms. Quarantine is not for people who are ill. Isolation is for people who are ill. So quarantine is some degree of removing people from public contact because of an exposure they've had. There is almost nothing good about Ebola in any way, but one of the very few things that's good about the virus itself is the fact that you're not infectious if you're not having fever and symptoms. And therefore, there's not an evidence-based way to justify keeping people away from all human contacts if they have no symptoms and no fever. And so careful monitoring, risk stratification is appropriate, but sort of blanket quarantine of those who may have possibly had an exposure, even in the lowest form, really doesn't make scientific sense. And so I think quarantine really, first off, needs to be stratified in terms of the way the CDC has done it, looking at your risk profile. But also, again, I think an overarching restriction of no public contact that doesn't make scientific sense.
Yeah,
Anyone
I
else?
totally agree. I think, exposure doesn't mean infected. And all exposure means is that you have been around someone who happens to have a disease. And we know this from all the infectious diseases, that lots of people get exposed but don't necessarily get infected. And with a disease like Ebola that is transmitted from body fluids of infected individuals who are symptomatic, it takes a lot of exposure in order to get the disease itself.
And I was going to say, I think we have evidence from our own experience with Thomas Duncan and his close contacts. I mean, his family members and all the community contacts, none of them have developed the symptoms, and that really supports the evidence that we already have in terms of the transmissibility, not just that there is none in asymptomatic patients, but that it's very low early in disease.
You get some people here from the business community, and I think some of them do a lot of international travel. What precautions should they take when they are going on these trips? Anybody want to weigh in?
I think that the sad thing about this disease is that you tend to get sick very quickly. And so majority of the people who actually have transmissible disease will actually not be traveling. So in some ways, that's good from a public health perspective, because I think that you may have someone who may be early in their disease, but hopefully we're catching those people before they're getting on the plane, and we're catching them on this side. Certainly, I think, I heard Pierre Ronald, who's one of the viral hemorrhagic fevers gurus really for the last 30 years. And, his point is that the amount of virus in your blood is what decides how contagious you are. And the amount of virus also decides how symptomatic you are, which means if you're not symptomatic, your ability to sort of transmit this disease is very, very low. So I would say, rest assured, I think the chances are very, very low that this is a risk to your health. If not, I never say zero because scientists never say zero, but if I wasn't a scientist, I may say that.
I think the key, and I'm sorry because certainly I'm going to repeat myself several times on this, is again evidence and science. And for those in the business community, they may or may not feel comfortable assessing the risks themselves. But the key is to establish contact with those that can translate what's being said, what's known, into responsible policies for business. And certainly the State Department does a good job with travel restrictions, and it's good to keep on top of that. But not to necessarily feel that you have to go beyond that, and to understand how important it is that we continue our normal business, both for the health of business companies, but also, frankly, for the health of the economies. When properly advised, travel is incredibly low risk. I think people are so concerned about being on an airplane, being in an airport with someone who could be exposed to Ebola, let alone infected, and those risks are vanishingly small. So it doesn't justify some of the wholesale restrictions on travel that have been discussed in the business community. And I think, again, particularly for those that have business services, health services to offer in those countries with right access to health information, it's actually vitally important that we continue to support these countries and these economies so that they don't have long-lasting health repercussions well beyond the Ebola outbreak. Again, I think, as again Nahid had said, it's tragic to me that childbirth pneumonia, appendicitis is going up in its mortality in all these affected countries because patients can't get to hospitals, they can't get care that they need. A similar parallel is really what's happening to the economies. I believe that, I'll get this quote possibly wrong, but the president of Liberia had said that her entire country uses less electricity in a year than Cowboy Stadium. It shows you the scale of where these economies are and how vulnerable they are to interruptions. I think we have to know that we all have some responsibility to help support the health and, frankly, the economy of these countries.
And the infection control components that will help you protect as a traveler from Ebola, such as hand hygiene, respiratory etiquette, cough etiquette, actually, thankfully, will protect you from influenza, which is much more likely to be, what is transmitted on planes and such. So, I think that the very common things we practice every day.
And also, even within this outbreak, I mean, there was not only evidence in the Dallas case where, 4 family members were in close contact with this individual for several days after he was symptomatic, but we also have a case of a physician flying to Nigeria with symptoms, and nobody on that flight became ill. So again, this is very, very difficult, and it is true that the infectivity of an individual, potential infectivity, does increase with viral load over time. And so late-stage disease is much more infectious than early-stage disease.
Dr. Childs?
Just a comment about post-Ebola. Obviously, increasing the healthcare capacity of these countries is going to be very important. But one of the things we're facing right now are food shortages. And we've already seen individuals, I think there were several hundred individuals who left a quarantine facility or an isolation facility in Sierra Leone because there was no food. And as we quarantine various districts or even portions of a city, providing critical resources is essential, or else we're going to see another devastating impact following this one. And this Ebola outbreak, generally the rainy season is from about approximately June to September. We've heard reports about large numbers of people who weren't able to get their crops in the field or harvest them because of the Ebola impact on family members and workers. So we're going to be seeing long-term sequelae which really go well past the building medical infrastructure.
Yeah, I think the estimates are, as much as losing 3% of their GDP, just from this current outbreak. And if that continues over time, it's going to really bode poorly for these countries.
And honestly, the international marketplace has a role to play. I think it's not just delivering aid and food in, but actually buying their crops. And there was a conversation from some of the UN folks who have been working on this in the field and really taking their cocoa crop, continuing the marketplace participation of these communities is a huge part of maintaining a sustainable, continuous support for them rather than just providing food aid.
There are a few representatives here of colleges and universities. Should they be aware of any heightened precautions that they should take for their faculty, students, surrounding communities?
I think it's incredibly important to lead as much as possible in this area, and what that means is lead in identifying who could go over and who could come back, and provide them the right expertise for what they need to know. Some of us will have staff who do travel over directly to affected areas and assist with either research or direct clinical care. And again, that's an important effort. But not everyone who wants to go or who may go is quite as experienced as Dr. Bhadelia and some of the others. And it's very important that we provide anyone who is wanting to go a full, very honest, very candid assessment of the risks and benefits and of how they can protect themselves, both again before, during, and after that trip. I think that leadership is incredibly important. And for example, we, within Partners, have a very extensive briefing that we do ahead of time. We have robust systems to track people, even with moment-to-moment text messaging services, so we can help keep an eye on folks and give them up-to-date information and still help repatriate. I think that's very, very important. I think the other thing, though, is to try and make sure that those who are going to go or those who are returning are welcomed back into the community well. We've had differing experiences reported around the country, and different people have had different kinds of experiences when they come back about how welcome they are if they've been to an affected country, certainly if they've been providing direct care. And I think we need to make sure that we do welcome people back, really recognizing for those that provide a direct service, the benefit and the risks that they've taken on their own. But even for those who just have family who reside in those countries and travel back, we don't want them to feel like pariahs when they come back.
Just to comment on that, Yale received quite a bit of attention, and much of it not positive. Two of our PhD students, well, one PhD, one postdoc, traveled to Liberia very early on to provide IT service to the Ministry of Health to help track patients and to look for contacts. These individuals traveled virtually independently of the university. When they came back, there were a number of horror stories, which if we have time I can always go into. But the university was extremely divided, and there was no policy in place for how you deal with individuals, professionals who want to go and work on these outbreaks. Nothing. So the university has scrabbled to come up with these guidelines. And of course, whenever universities or administration gets involved in these things, they're rather cumbersome. And I think if we had had this in place, these students would have never made it over there. But universities and other organizations are responding to try and come up with policies to deal with this. This isn't the first time students have been in harm's way. People travel to South Africa to work on HIV and extremely drug-resistant TB. We've had students in the Caribbean working on chikungunya, but there was no strict policy for this sort of activity.
Maybe you want to touch this and maybe you don't, but in your expert opinion, what do you think the federal government or the CDC could do better in the future? Anybody want to touch this to say, yeah, they dropped the...
I'll touch it. Having
we're among friends, it won't go any further.
Having worked at the CDC,
Yeah.
one of the things is there's been a lot of finger pointing. Now, CDC has a group of experts that respond to these sort of outbreaks, but there are very small numbers of people who do. So all of a sudden, there's concern in the United States, and CDC is expected to provide hundreds, if not many more people to train folks in protective gear in which they've never had training. So you have to understand, it's not like this whole organization is training people to do this specialized work. There are actually very few. The CDC appears to have dropped the ball in some areas. Again, one of the things I still don't know about Texas is the CDC cannot go into any state unless they're invited. And I still don't know what the situation was in Texas and how this was handled. So it's been a very hot potato. Now CDC has come out with these recommendations, which I think are very reasonable. And I think they're a starting point to get some uniformity to how we respond. You're all aware about different states responding to various incredible measures. Almost all have been retracted to one degree or another. You know, the situation in New York and New Jersey. So I think even if there are differences, I think the CDC guidelines are a good starting point. And one thing you have to know, the CDC does not pass. It's not a regulatory agency. But normally when they make recommendations, a lot of people take them serious as though they are coming down from a higher order.
I think
I'm sorry,
please.
no, go ahead.
I think the messaging here is really, really hard to get exactly right, and I think it's hard for me to fault anyone on this. I think early when we started seeing the threat of Ebola in the United States, what CDC very much didn't want to do, and I can't, of course, speak for them, but I think all of us wanted to do was make sure that hospitals didn't throw up their hands and say, we can't do this. This is too scary. This is too different from what we want to do. And it's very possible, though unlikely, that a patient could be exposed in West Africa to Ebola, travel to the United States, and present to any hospital in this country. Again, very unlikely, but absolutely possible. And therefore, every emergency department has to be able to identify, to isolate, and begin the care for a patient. And there was really a risk, I think, as this was becoming prominent on the national radar, that hospitals would just say, I can't do this. Again, I need a BL4 laboratory to be able to do this. And so the messaging had to be, you can do this, and we do contact precautions. We do infectious disease control every single day. On the other side, there has to be a recognition that this is in fact different than all the other diseases that we deal with that have contact isolation, that the volume of fluid potentially that can be produced by a late-stage patient, the infectivity of that fluid, the precautions and the precision with which you have to don and doff is different than what we do in daily health care. And it requires more practice, it requires more specialized planning than what we traditionally do. And so a messaging of you can do this, but boy, you really have to work extra hard and develop different kinds of protocols, I think is a subtle message that's hard to deliver from a national guideline. Thankfully, I think the message of we all have to be prepared has gotten out. I think it's taken longer to get how we're going to be prepared, both in an ED or in a reception of an emergency patient versus provision of ongoing care to that patient. And we've been evolving, I think, as a nation, but we're getting closer. But it's hard for me to fault folks for trying to thread really, forgive the pun, but is the small knife the needle.
That's quite all right. We use it too.
Not the first time I've heard it.
Yeah. One of the other things I wanted to mention, I think as a researcher, I would be remiss if I didn't bring up the whole issue of funding. The CDC, like other federal agencies and like university research pools, are under incredible financial pressure because of the restrictions on funding to fund their activities. And that includes many of the important activities that the CDC is expected to carry out. And I think, our policies and how we think about how we fund public health and surveillance as well as research has a significant impact not only on what we can do, but how rapidly we can also respond to things like this.
Someone asked me the question here that I said I couldn't answer it. You got to ask the panelists, but they asked a question about how serious of a threat is this dreaded disease spreading here in the United States?
So, I'll dwell a little bit about what the actual environment is like in this Ebola treatment institute, so you can see the comparison and contrast to what we have. No ventilation, 100 patients, fluid all over everywhere, not enough hands to clean up the environment to ensure that it's not a risk factor for healthcare workers. Healthcare workers who are not that trained, not that many healthcare workers. It is a completely different environment. And, I think that's why when the CDC speaks about this with authority, as they should, that the chances of this becoming a generalized epidemic, I will say, are zero here, because it is a very different environment there. If I can only provide the contrast, you can tell why it's spread there.
Okay. Anyone else? No.
I think, again, it's the difference in environment and it's the difference of the disease. That you're not infective if you don't have symptoms, and that means public health contact tracing. If, God forbid, I have the disease and I start showing symptoms, we will keep an eye on the people I've had contact with and keep them appropriately away from others if they show symptoms. But that stops the ongoing transmission in its tracks, and that's because we have a robust public health system in this country that we're very grateful for, and we have resources that unfortunately aren't available in much of West Africa.
And Senegal and Nigeria are, the proof in the pudding.
Mm-hmm.
They have slightly stronger healthcare systems and public health systems, and they were able to lick this.
Let's just take a second just to talk about preparedness here in New England. In particular, what steps are you seeing hospitals taking to prepare for possible new cases? Are they doing the drills with staff? Are they doing simulation? Are they doing
Yes.
All of that.
I do think, it's worth noting, both for community hospitals and for the academic medical centers, how much really is going into and has to go into preparedness for this. And again, I think it's different, and we've been doing preparedness for a very long time in our hospitals. A lot of what we're doing right now at the hospitals I work with builds on things we've been doing for SARS, even for anthrax, 10, 15 years ago. So this isn't something you start day one and are trying to develop. But that being said, this requires an awful lot of new work. First off, the personal protective gear that is required to keep you safe from the amount of fluid and the infectivity fluid that could be generated, not always is, but could be, is different than the normal healthcare personal protective equipment that we wear. And what we do know, tragically from the exposure from the nurses in Texas, but from others as well, is that you have to really, really be close to perfect in how you put it on and how you take it off. And I will say this as one of those potentially arrogant doctor types that just takes on and throws off the gear without thinking about it the way we should. That doesn't work. That doesn't keep you safe. And so we've all, I think every hospital in the state has put together a lot of effort to train and retrain their staff in how to don and how to doff the personal protective equipment. And hospitals have spent an enormous amount of money purchasing new personal protective equipment. For my own hospital alone, since the outbreak began, this is approaching $250,000. And there was a CDC conference call yesterday across the country, and there was a 25-bed critical access hospital in the country that was in the many tens of thousands of dollars. And as a proportion of their budget, you can probably appreciate how significant that is. On top of this, for ongoing care, if we're really going to have, again, 3-week potential hospitalizations, it's been about 3 weeks that folks have spent in the United States in a hospital. How we have to change the environment of care really is different. And so we actually have, in the middle of all of this, knocked down walls in our medical intensive care unit, in our emergency department, and others, to be able to provide the safest possible environment of ongoing care for these patients. So the financial costs, especially for those that may care for a patient more longitudinally, again for weeks, are absolutely substantial and enormous. But I think the way in which the health system overall, all emergency departments, are changing their training, their practice is dramatic. Last thing I'll just say is there's a very small silver lining in the tragic case of Mr. Duncan, which is I think everyone across the country understands the importance of a travel history differently than they did earlier, and that's good for all infectious disease outbreaks across this country. We should be doing this. This is part of primary care, of urgent care, of emergency care, and the fact that we're asking about travel history will also help us for MERS, for SARS, for H7N9, for all the other infectious disease threats that are out there, and whatever else I think it is we're going to see in the future.
Is that training hospital-wide, or is it just ER staff people?
So it's not just emergency department. I think every hospital is different in their specific plan. But I do think almost all of us are consistent that it's focused. Again, I have 25,000 employees at Mass General where we work. I can't possibly train 25,000 people to do this very, very well. So we have a very small number. The number is about 350 between emergency medicine, medical intensive care unit, pediatric intensive care unit, respiratory therapy, dialysis, anesthesia. We have a couple groups, and so 350 still to me is enormous, but I can't get that number smaller. But that's what it takes, and it's a lot better than 25,000.
And I think the other reason to sort of reduce the number of people is to reduce the number of people who go into the room, to reduce the risk. I think just education at different levels, just as general amount of education for the general public and the hospital and everybody else. And then, as Paul was saying, I think a concentrated super user group that is able to take care of these patients and do so safely.
Doctor?
This conversation is obviously focused on the U.S., but I think everyone can appreciate the expense and the manpower which goes in handling maybe a single case in the United States. So compare that with what we've got in West Africa. Right. We're building all these facilities. How many people, how much money? Maybe now he can answer it, but if you have a 25-bed facility, what's the estimated number of professional workers, not just doctors and nurses, but the people who clean the floors and the technical staff? I don't know the estimate, but maybe
Well,
you do.
And I don't. If someone had quoted me a number, and I do remember thinking it's pretty high, but I'll quote this. I mean, you change this personal protective equipment. Most of us went in twice into the Ebola treatment unit. Those Tyvek suits and all that stuff, that's really expensive. It's thousands of dollars weekly spent on this for just the personal protective equipment. So I can't imagine what the cost ends up being.
I mean, it seems like the teaching hospitals are pretty up on this issue. What about the rural hospitals, the small ones in Western Massachusetts, New Hampshire, Vermont? I mean,
Well, I certainly can't speak for
are
all
you
the.
sharing any information with
We're
them?
definitely sharing
yeah.
information. I think through efforts like the Department of Public Health and the Commissioner's Office, we're getting a lot of best practice sharing. The CDC has been trying to do this. ASPR, the Assistant Secretary for Preparedness and Response, has put out toolkits. I don't think it's reasonable to expect every small hospital to be able to care for 3 weeks for an Ebola patient. Again, some of the places have estimated it takes 40 or 50 staff just dedicated to one patient within a facility, and that may be the entire employee on duty shift for certain hospitals. I do think, again, every ED has to be able to isolate, identify, isolate, begin care for a patient. Every emergency department, every hospital should have a relationship established with a hospital that can provide longitudinal care. There's been a lot of discussion about whether Emory and Nebraska and the NIH, the facilities that have been drilling and practicing for this for so long, can serve as the only resource for the United States. I think that's not true. They are spectacular, and what they've done really has to be acknowledged. It shows the value of being thoughtful in planning ahead for emerging infectious disease, actually for my colleagues here on my left, that are working to help advance overall the care of infectious disease. But there are fewer than 20 beds among those 3 centers, and that's not a national approach if we have something that is more transmissible, if something that does threaten to provide it to be a larger outbreak. So there's definitely, I think, a strong argument to be made for at least regional capacity in this country. I do think, for what it's worth, we should be having a national dialogue on standalone treatment facilities, and I say this because the operational impacts and the public impacts of having a patient with either possible or confirmed Ebola at your facility are dramatic. And I think how the public perceives risk if someone is hospitalized at your facility with possible or confirmed Ebola is enormous. And none of us is in a position to sustain dramatic fall off in the visits to our emergency department, our elective surgery, our hospitalizations, and no one is going to pay us for that lost revenue, and it threatens, I think, the financial viability of hospitals. So to have, and what's proved very successful in Emory, frankly, and Nebraska, is to have a standalone, dedicated, purpose-built facility that can be run by the same experts, but everyone feels reassured it's separate. I want to say very, very, very clearly, we feel confident in our plan to be able to care for a patient with Ebola virus disease inside a facility and put no one within that facility at risk. And I think everyone has been making those plans and feel incredibly confident. But I think we have to deal with the reality of public perception, and we will be working with our fellow hospitals across the city if any one of us hospitalizes someone with Ebola, and we'll be working with the public health leaders in our state to message that is safe and that no one should feel concerned about the care that they're receiving. But I think we have to recognize that as a long-term goal for a strategy of emerging infectious disease, this is an important priority for the country.
And I think I'll flip the conversation on the other side. I think preparedness is such an important part, but and I think in West Africa we can still go so far with good supportive care. We have such a distance, that we can take this to improve mortality, improve the survival rate. But here, I mean, and there, I think eventually therapeutics and vaccines are so important. That's why research is so important. All this conversations about stigma, particularly with healthcare workers. And those returning. Imagine if we had a vaccine for healthcare workers. I think that we cannot underscore the importance of continuing research with vaccine and therapeutics as well.
That was one of my questions towards the end to ask is, will we ever find a cure for Ebola?
Well, as you probably know, there are 2 experimental vaccines that are now entering clinical trials. There are a number of therapeutics that have been kind of thrown at patients, literally, in the U.S. That have essentially no stockpiles of those therapeutics. We have no idea whether or not they actually mattered. because a clinical trial has never been done on these. So will we be able to find a vaccine? I think the nature of Ebola and the way it changes its genetic makeup makes it highly likely that, in fact, we will be able to develop a vaccine, in my opinion. Whether or not the two that are there are the right vaccines, whether they're the ones that we're going to want to roll out on a continuing basis, I don't know, but they're certainly worth trying at this point in time. And they both work very differently. One is really a pre-exposure vaccine that you have to develop immunity over time. The other works actually both pre and post-exposure. This is in non-human primate animal model studies. We don't have a clue. We've only had one person that we've ever followed an immune response to that's been immunized with an experimental vaccine, and that was a worker in a BSL-4 lab in Germany that took it several years ago, and we were able to follow the immune response over time. But, you know, there's a lot of work to be done.
I think on the clinical side, you know, we have some ethical things to get around with these therapeutics as well, because the only way to scientifically prove something works is to pit it against the standard of care. But imagine being the person who gets placebo if you have Ebola, right? I mean, I think these are tough questions that we have to answer as a medical community, as a research community.
Just to comment also, the two vaccines which are in use were developed at national centers. One's the National Institute of NIAID vaccine, and the other was developed at Winnipeg in Canada. And let's face it, these are orphan diseases. To develop a large number of vaccines, drug companies are probably not going to be interested in doing this in any case. So relying on public facilities to develop this response and produce sufficient vaccine, for example, in this sort of situation, I don't think is ideal.
It's interesting. Someone made the analogy to me, and it may or may not break down recently. But you know, we don't ask the market to develop fighter aircraft for the military, and then once they're fully developed and they put in all their money, then see whether they can sell it to the government or not, and whether or not we want to buy it. But that's exactly what we do for vaccines. We decide that the protection of the nation is worth investing dollars up front, and then we award contracts to certain vendors that we think are very highly likely to succeed, and ask them to help keep us safe. And instead what we do is we ask the market, we ask for the most part, we ask pharmaceutical companies to develop something at their own cost, and then if it works, great. But we might actually nationalize it and take it away from them. And I think we should probably think about a different strategy for bioprotection, about those things that we think are most important, and how we're going to invest our dollars so that we get faster to the finish line with vaccine development and certain biotherapeutics.
Kind of goes into what the doctor said earlier about the federal cuts in NIH, and in particular that you know, that's part of the problem that we're facing now is with the the federal budget on the decline in areas like this, the NIH since 2009. It's not a hopeful sign, to say the least. But I must say that the members of the delegation from New England are very, very vociferous in their support of NIH funding and to, put it back on the climbing angle. But it's so important, as why we're talking here today. Let me just ask.
And we're very appreciative of
yeah,
that
well,
support.
you got great supporters in the delegation. I mean, you should thank them because they're all very, very vigilant in making sure. It's just unfortunate with the climate in Washington. It's not as high a priority for other members in parts of the country. Just getting back to the outbreak, how much longer do you think this will continue and being in the pages of the newspapers? You seem to have a good handle on it.
Yeah, I think that, it depends on if we're talking about the first wave of just the Ebola, the mortality and morbidity from Ebola. I think you're seeing some good news finally from the field with places like Monrovia and stuff. And the issue is that majority of our models are, again, based on reported data, and we don't have a good sense of what's going on in the field. then most people before this news from Monrovia would have said that we haven't reached the peak, that we're still going to see a lot more patients come up at a daily caseload before it turns around. Now I don't know. I think your guess is as good as mine. I think, and WHO would probably say the same thing. I do think we'll see at least a few more months of slightly increasing cases before it actually goes anywhere close to it. But that's just the first level. I think the second wave, the impact on the healthcare system and the morbidity and mortality from that is going to be immense, and I think we're going to be dealing with that for years.
The other thing about all of these kind of niche diseases is they're all zoonotic diseases, which means they move from an animal reservoir into humans. The fact is that this virus has been in West Africa for 8 to 10 years. It's been there undetected. There's some retrospective studies that suggest that there have probably been small outbreaks in the past, and so it's going to be in an animal reservoir, and as in Central Africa, where there was a small outbreak in DRC, there was a Marburg outbreak recently, there are going to continue to be these spillover events. So even once this is fully controlled, I think we still have the problem of how we're going to prevent that spillover from occurring again and recognize it when and if it does.
That was my other question. What other dreadful diseases are coming along that we should be aware of and be prepared for?
Well, there's a new infectious disease that impacts humans that's recognized on the average about once every 18 months. So, this unfortunately is a growth industry. And I think the lessons that we're learning now, I mean, if there is any silver lining in this outbreak, is that people really do understand now why it's better to be able to treat the diseases where they occur rather than allowing them to get to this point. And every one of them has this potential.
Mm. And to complete the loop on Ron, sorry, go ahead, Charles.
Oh, I was just going to say the data coming out of Liberia and Guinea, it's less promising in Sierra Leone, at least indicate that in major centers the incidence of disease is declining. I think there's a lot of caveats to that because we really don't know what's going on in more remote areas. But once again, there are neighboring countries, and if this virus gets into Ivory Coast, Ghana, whatever, we're going to see a whole nother crop of patients. And my own guess is that once we see this decline, we're going to see sputtering outbreaks for quite a while. And obviously, we've never had up till now. And obviously, because of the zoonotic reservoir, we're going to see Ebola outbreaks over and over and over again. Since 1976, really the major outbreak, there have been other small ones, occurred almost 2 decades later, in 1995. But since that time, we've seen virtually case outbreaks every year, varying size.
Just closing the loop on what Ron was saying in terms of zoonosis, I mean, you have areas that have deforestation, where you have poor communities, where you have lack of economic opportunities. I think that's where you're likely to see more human to animal contact. And I think that's really is a case for economic development, just economic development for these communities and support, and this is where I think Marketplace has such a big part to play in helping reduce zoonosis, aside from all the things that we've talked about in terms of disease surveillance and treatment and healthcare systems.
Just to comment on that, I think that this is a two-sided sword. If you look at places like Ivory Coast, there's been huge change of land ownership to international companies which are interested in cacao and other plants. And indigenous tribal persons are being displaced from these areas at a startling rate. There's some very good articles on the impact of economic development and land use in these countries on really disruption of traditional social systems and causing vast movement of populations throughout these countries. So that, yes, development is very important, but I don't know how one steers it towards processes which ultimately may be detrimental and may lead to more outbreaks as forests are cleared for planting.
Sustainable. Sustainable.
Okay.
Okay, I'm going to open up the floor now. We have a mic. The young lady is going to be looking for anyone that's raising their hand, and if you could just identify yourself, we're going to ask Laurel Sweeney to ask the first question, our chair of the Healthcare Committee, to ask.
I just wanted to just follow up on the discussion around animals. You know, the book, The Hot Zone, 20 years ago, but a lot of the focus was on animals being used for research and how it was spread over, or potentially could spread over here because of that. How has that changed since then in terms of controls over that? Or we've talked a lot about people infectious diseases, but can you address that issue?
Yeah, the concern, I mean, most people in the infectious disease world, you know, have accepted the One Health motto of, you know, this is not only a people concern, but it's also an animal concern as well. That particular disease was actually an Ebola that came from the Philippines that, as far as we know, doesn't actually cause disease in humans. It's the one so-called filovirus that's endemic outside of Africa. Most of the experimental animals that are used in research, because you can't really develop a diagnostic or a vaccine or a therapeutic without using animal models to show you that you're on the right track. These animals are screened very carefully. Most of them come from breeding centers that develop them specifically for this purpose. These are not wild-caught animals. So that was a very unusual type of episode, but it was one of the things that also drove people to think very carefully about how they use animals in research and where they get them from. Yeah.
Our co-chair of the Healthcare Committee, Joe Alviani.
Yeah, just very quickly, I just wanted to both reinforce something that you said and also have it in the form of a question, and that is that we tend to have very, very short memories in the United States. And my concern is the concern that you raised about what happens to the healthcare and public health infrastructure in these countries when the hysteria over Ebola leaves and you have all of these remaining conditions and diseases that continue.
Well, you know, this is already an ongoing conversation because as all this money is being poured in, almost all the actors who are involved have started thinking, how do we make this a sustainable investment in the healthcare system? Because I think everybody recognizes that if they had stronger public health systems, and you know, and in some ways, I think that's a good thought. A lot of it comes down to good governance, you know, in some of these countries, and that's always going to be a challenge, you know, because that's not something that nonprofits can necessarily come in, particularly as they're doing with this, can change that. One way that people are looking at this is training healthcare workers with the purpose of responding to this, but also then actually in a grander way to respond to other common diseases in the communities. And particularly actually hiring of survivors from Ebola, those who may be potentially immune to this for a long amount of time, increasing their training, their social status and economic opportunities. But I think it's still an ongoing conversation. I think it's on everybody's mind. And I agree with you. I think I have a concern that we're all going to leave it.
Yeah, and I was at a meeting with several West African ambassadors a few months ago, and that was one of the things that they were pleading for at that time is that we can't swoop in, solve this outbreak, and treat it as if we've done our job and leave, that they really need the infrastructure built there. They need, in particular, people on the ground that can do this type of work safely.
And although I very much want to agree with my colleagues that you know, the emphasis has to be on rebuilding health systems and on supporting West African countries as they recover from this terrible outbreak. But we also have to recognize we have to sustain our own national health response and preparedness efforts. as I mentioned, a lot of what we're doing in our hospitals here builds on work we've been doing for a decade or more with health preparedness program funding from the federal government and others. But that funding is under tremendous threat. The hospital preparedness program has been cut 38% just from last year to this year alone, following on the heels of many years of successive cuts. And it really is hard to imagine that in 5 years we're going to be better prepared than we are today if we continue this dwindling investment. And I think we're all in agreement, the threats are actually increasing rather than decreasing across the globe, certainly, but also across the country.
Yes, sir.
I work in the biotechnology industry and have been responsible for starting vaccine and drug development companies. I think that this tragic epidemic has a silver lining. There are two components. One is the understanding that we need to pay more attention to helping stamp out these diseases. And secondly, we need to be able to focus our attentions on methods that are not supported by the government. The example, we tried to make a universal flu vaccine 10 years ago and were told by vaccine companies, we don't want that. We don't want a single-shot vaccine like measles. We make a lot of money out of our rather inferior flu vaccine. So I think there are many lessons that we learn from this to our advantage if we can take part in resolving them. Thank you.
Anyone want to?
Okay.
You want to bring the mic down, Meredith? Just identify yourself, too.
Good morning, John Brennan, Cambridge College, City of Taunton. How is the Ebola czar doing, and have you spoken to him?
I can say I've not spoken to him, and I would say it's too early for me to have a sense. I think we've seen tremendous increase. Well, let me phrase it differently. We've seen a wonderful amount of support from the federal government in the last couple of weeks in terms of specific protocols, in terms of outreach from the CDC, from the Assistant Secretary for Preparedness and Response, from other agencies. And so I think though it's been frustrating for all of us, I think at the local, state, and federal levels, to deal with all the evolving information, as is normal in any outbreak, that you get more information, you see things differently. I think we're in a much better position than we were, say, 2 months ago, 3 months ago, in terms of what we know and what we're trying to all do together. So I think I can definitely say there's been quite a bit of progress at the integration among all the levels, but I think specifically to that question, I just don't know yet.
Yes, ma'am. Just identify yourself.
Sue Sullivan, Newmarket Business Association. I represent a couple hundred businesses in Boston, and I'd just like to address that the layman's hysteria as we talk since we're talking myth versus fact. What I've heard today is that by the time someone is symptomatic, they're not traveling for the most part, and that they're not going to. We have a 0% chance of a mass outbreak. What I'm hearing a lot from my business community is what about, and of course this morning we also had on CBS News, they talked about if you're on an airplane and someone sneezes, I don't know if anyone saw it, where it all goes, okay, on the airplane. And a lot of people are saying if someone is not presenting as symptomatic, and they're traveling, and they sneeze on a plane, or they get back and they're feverish and they sneeze in the workplace, what I'm hearing from you today is that is not going to infect the rest of the people either on the plane or in the workplace.
The good news is most patients with Ebola don't sneeze. So,
no, I'm saying,
yeah, a lot of it is. Majority of it is coughing later in disease.
Right. It's not. It's not
they
a
could
disease.
have a cold though, and they could have Ebola. Is what I'm saying. They could. I want to make sure that what I'm hearing, because I'm going to go present this to other people, that that is not going to happen.
I think the new system instituted at the ports of entry by the CDC to identify and track folks coming back from those countries, the individual state tracking protocols of identifying anyone at low, medium, and high risk and counseling them as well as monitoring those folks makes it extraordinarily unlikely that anyone who's had a plausible exposure to Ebola will present unrecognized really anywhere, certainly in a workplace, even in a hospital setting. I think the idea that they would just show up in one of our clinics without communicating with public health authorities and without them communicating with us is exceptionally low. I can't say zero, again, back to the scientist question, but is extraordinarily low. And so I think everyone in the workplace should feel very confident that there's really no chance that they're going to come in contact with someone who's been exposed to Ebola. I would, again, be remiss as a public health professional to say, remind them to cover their cough, wash their hands, don't come to work sick, because those are the great public health interventions, especially as we head into flu season. But for Ebola, they should feel very confident they're not at risk.
I think one thing everybody has to understand about Ebola is that its primary sites, particularly early in infection, are lymph nodes and liver, not lung. Yeah. It's only very late in the disease course where you start getting vasculature infected and you start seeing some of these other changes that could lead to droplet types of contamination. So, flu, common cold, those are things that are spread, from the lung because that's an early site of where those diseases occur, but not in the case of Ebola.
Just
Dr. Childs?
one comment. Our experience with passengers on airplanes and Ebola obviously is limited, and I agree with other people that the transmission is very hard, and but we don't have a lot of information on this. We're going to get it, and certainly there are lots of diseases in which you can get spread, often those in which you are infectious before you're symptomatic. So I think the risk is just extremely low, but you have to remember our experience is extremely low also.
We do have representatives from airlines here today, as well as hotels. Are there any precautions that they should be aware of take?
Well, before I go there, I just wanted to speak to the flip side of this. I was speaking to first responders at the local emergency preparedness committee, a couple of weeks ago, and one of the firemen said, how do we deal with the fact that we may find someone from that general area of the world who might come in with influenza, who's on the street or has a heart attack on the street, and now you have this mass panic? And there was this huge conversation among first responders about how do we maintain our humanity? How do we maintain the respect for the person in front of us? And I think we need to concentrate on that. We need to concentrate on what the cost of our panic is. I think we need to. This is why it's not just always good to go by abundance of caution, because it does have its costs. So I'll say that, and I'll let anybody else take the airline or
the airline and the hotel representatives that are here.
Sure.
Should they be aware of any precautions?
I was just going to say that we have a 24-hour epidemiology line that you can call, and our epidemiologists have walked many people through scenarios that they're scared about that are low risk. And it's better to call us than to call hazmat first, because then it turns into chaos. We have politicians making policy and deciding what to do, and rightfully so, they're trying to reduce panic in their community. And we've had several dozen cases that are low risk that we've walked people through, and they do a really good job if you start with us first. So we have a website, mass.gov/Ebola. There's information for communities, there's information for providers. We do have calls every single week with thousands of EMS and other public safety professionals, hospitals, health centers. So get on a call, we'll give you information. We're on calls every day, all day, and really want to help get the right information out to everybody. So,
Thalia?
An assessment of how much damage you think has been done to the reputation of the CDC and its long-term consequences? Because that, to me, is a serious concern.
CDC has come under fire a number of times, and without a doubt, I think that there have been a number of occurrences in recent months, not just how CDC has handled this particular instance, but I think everyone may be aware that CDC in packing and providing influenza samples managed to include an H5N1 influenza strain in that sample. And this is the bird flu from Hong Kong with very high fatality in humans which get infected, low transmissibility. And then we had the debacle at NIH where they're finding certain things in their freezer. I think this has done damage to the view of our public health agencies, although I feel that, as I stated earlier, a lot of the criticism and finger-pointing is based on a lack of understanding of how these agencies work. Now, if you look at CDC's budget, it looks pretty impressive, but almost all that money goes right out to the states. And I think that this is going to be dissected over and over again in the months ahead. I'm sorry about the damage to CDC. I think it's somewhat inevitable when people start pointing fingers, especially politicians. And there's one other point I was going to make, but I had a senior moment. If I remember it, I'll come back to it.
Okay. You have the mic, and then I'll get Joe. Go ahead.
Yeah, I'm David Romy. I'm a medical director with Tufts Health Plan. Thanks for sharing your expert perspectives and your practical experience with us this morning. It's very helpful. But my question is really specifically about the Ebola virus. So what's the current thinking on the probability or possibility of a mutation that could change its virulence or some other significant characteristic that might affect its infectivity or the course of the illness?
Well, there are very few examples. I mean, there's almost no good example of a virus that changes its mode of transmission once it's in a human population, for example. So the chances of Ebola doing that, I mean, if you start kind of mentally thinking about it, let's think about it changing into something that would be spread through air. The way you spread things through air is you cough them, which means the lung now has to become a primary target in addition to the fact that you've got to be able to cough this virus up. So, I mean, the hurdles, the biological hurdles that the virus would have to reach in order to get through all the barriers to from where it is now to turning it into a virus like that are so large, the chances of that happening are essentially nil. And again, we have not much experience with Ebola, but we have tons of experience with lots of other viruses, and they just don't go through that process.
And just a comment, if you look at viral evolution or pathogen evolution, at two extremes you can see one, evolution towards extreme virulence, which has its own problems because if you infect everyone, they're all dying very fast. You've got nowhere to go. But it can increase the probability of transmission when an infected person contacts a susceptible person, which can increase the reproductive rate of these viruses. And at the other extreme, you might have evolution towards a longer duration period in which people are surviving or are less ill, but are infectious for longer periods of time. So the virus may, in that case, is becoming potentially less virulent. And usually what you see is somehow they reach a happy medium, but there are likely, all RNA viruses are, usually they're very different from each other, even coming from the same cell. So mixed populations may have mixed characteristics, but I don't know which way it's going.
And I think just the question itself, there's been, I know, a lot of concern about this, but the question itself should also raise the corollary question of, are we investing enough to know as much as we can possibly know about these viruses? Ron's too humble to sort of make the plug, but I will, since I have no stake in this. I think this is vitally important that we do this. I think the more we know about these viruses, about their structure, about their common genes and differences, allows us to be farther down the curve and ahead of them as much as is possible. And so I think we do need to ask the question about what could happen, but I think we should should also be really asking the question of what do we need to do to know what is likely to happen. That's through science and good research.
Gentleman in the back.
I'm the other David J. O'Donnell in the room. I have 11 brothers, but I know he's not one of them.
Sure.
My big question is, what are we doing education-wise? This room is terrific, but there's a limited amount of people here to stem those fears about the spread of this horrible disease. What are we doing globally to make that happen?
I think there's an awful lot that's going on, but clearly I don't think we're still quite there yet. I think at the small level, hospitals have been working very hard to educate their patients as well as their staff on the realities of the disease, on care systems, on protocols, and I think all of us have seen that the more education we do, our staff certainly feel better, and it's a little harder to reach our broader patient community, but we're doing well. Or better, at least on that. I think we've been working very hard with the Department of Public Health, and Commissioner Bartlett, I'm sure, wants to say more about that. I think, CDC, ASPR, others have been pushing it out. I think we need help from those in the media being very responsible, and I'm not suggesting otherwise, but in pushing out the message that here's what we know, here's what we don't know, but here's what the real threat is. Commissioner, I'm sorry.
So the month of October, I think we've given 25 different presentations, from people in the hotel business to school nurses to every kind of provider that wants to hear from us. We are available. Dr. DiMaria is out and about. He's a really skilled and knowledgeable epidemiologist, our state epidemiologist for many, many years. We've had, I think, a dozen phone calls, again, with thousands of people on them. We've produced clinical advisories for every interest group from academic institutions so that you could actually have an algorithm to assess the risk of any of your students who may be returning from a country that has epidemic Ebola, to how a school nurse could address this if something would happen in a school, to local public health, how can they talk to their communities about this, to a mayor in the event that their community may have a suspect case, how could they handle it, who do they call. So we've produced and all of those, again, are posted on our Ebola website and are available for people. And if there's any other audience we've missed and we hear from, we'll certainly produce another document for them. So thank you.
Just to comment on that, one of the things which is, well, I would say shocking, but it's not, but disappointing about the response to this outbreak is the lack of trust in scientific information, which has, I don't know where states get their information over these drastic measures that they have recommended, but it clearly isn't from knowledgeable epidemiologists and science experts who would, I think, have very different change of opinion. And you can't believe all polls, but if you look at polls, a huge percentage of the population don't believe in science and the method and the messages which are being passed on, and it's unlikely that any educational program is going to change those opinions. Once you have conspiracy theories and so forth, data and facts don't have any impact.
Let me turn that a little bit, because I think you raise an incredibly important issue, and it's one that those of us who have been involved in this facility for a number of years have learned too painfully. And that is that we on the science side don't do enough to communicate publicly. And I think part of the lack of trust actually comes from our own mistakes of reaching out and doing educational programs for the public, engaging the public on a regular basis in a respectful way, listening to concerns. I mean, we've learned that very well here. And we're doing everything that we can to begin to develop the types of programs that will help educate, starting with, middle school children, but also talking to adults around the community. This is incredibly important. And it's not just about Ebola. It's about infectious diseases in general. And it's about research. And we have to be able to develop that face-to-face contact to show that we're not just nerds working in a facility, but we actually also want to exchange information, not with just our own nerd colleagues, but with the public in general. And this is something we've not done well over the last 10 to 20 years, and I think it's up to us to change that dynamic.
Gentleman down here.
Don Guadagnoli, I'm the Chief Medical Officer for Cape Cod Healthcare, and we've been involved in quite a bit of educational efforts, and I have a couple of very specific questions. One concern that keeps coming up among our staff is that can this be shed through sweat, and if it's shed through sweat, how easily could it be contracted that way? And the other is what are the odds of someone showing up miscarrying as a result of infection from Ebola?
So I think it depends on the amount of virus in the sweat, right? I think that's the big factor. It depends on how sick that person is and hence how much viremia there is. I mean, I think this was the exact same question that was posed to the expert that I mentioned before. And early in disease, I think the chances are very, very low. But I think that increases as you get sicker patients. As to the latter part of it, this is all anecdotal data. I mean, you may have, Professor Childs, more data on this, but we did see, a couple of women presenting with miscarriages with this, and that is one of the presenting signs of this, actually. And but what percentage? I have no idea. I don't have because I don't think we have the population perspective on that. Yeah.
But this is a particularly important problem for pregnant women.
Yeah.
We see early births, we see lots of preterm births, and oftentimes if they're infected, there's uncontrolled hemorrhage associated with. So you see exceptionally high mortality among women who are carrying a child, irrespective of how early or late it is in pregnancy.
But sorry, let me just add on to that. So the American College of Obstetricians and Gynecologists just recently released a policy statement on this, and regrettably, when they looked at the, albeit limited, data that's available, and this is in the West African setting, neonatal mortality is essentially 100%.
Yeah.
But I want to qualify that the chance of a woman presenting to one of our health systems who wasn't already identified and known to public health with a potential miscarriage or pregnancy problem to anyone, any health setting, is exceedingly low. And as I think we were alluding to before, I am far more worried about someone not getting access to appropriate health care because someone said the word Ebola and they had no plausible exposure than a patient with actual Ebola or exposure to Ebola presenting to the healthcare system. So I think hopefully as people understand how well plugged in these patients are to the public health system, that should lower their anxiety.
So I'm fairly safe. I'm an obstetrician by training, and my general response has been it's fairly unlikely that somebody who's in their second trimester of pregnancy is going to spontaneously decide to go volunteer in Africa.
I don't think that's most places are taking pregnant women.
Right. Therefore, that one we can pretty much rule out as ever presenting. Now, an early pregnancy presenting as a miscarriage is really where we need to be prepared. And that's where we need to have our emergency room prepared too, and not focus on the other.
Interesting comment.
Commissioner, want to say something?
Yes. So I think one thing the CDC has done a really good job at is the travel restrictions and the funneling everybody through 5 airports in the United States. And 70% of people traveling from these countries that have epidemic Ebola who have traveled to as U.S. citizens and come back or are traveling from one of those countries wind up in about in 70% of them in 6 states. And then Massachusetts and New England is probably in the second tier where some of the 30% of the people are going. So essentially, we will know everyone that has been in a place where they ultimately could have been exposed, high risk, low risk, no risk, although we're not saying no risk anymore. And they're all in a monitoring program. So when they come into those airports, everybody's checked in. They're sent to the state where their destination is. If they leave that state to go to another state for any reason, they then get transferred to our list, and we monitor them for 21 days. Depending on the level of risk they have, we either directly observe them every single day by a public health nurse and or a local public health person, and then if they're a low risk, they are taught how to monitor themselves and they're spoken to every day. And so I would agree that the risk of someone sort of slipping through unknown is pretty low.
Yes, ma'am. You want
Mary Gearing from the Boston home. First and foremost, Jim, you're taping this, right?
It's being taped, yes.
Great. I think that, first and foremost, is a good thing to play on TV and not just on C-SPAN, because not everybody's a C-SPAN junkie, like many of us are. So I think that that's extremely important. I think that the local media need to do more community outreach on this, as opposed to the fear factor, to do exactly what you're doing here today, which is very simple language for people to understand. It's not rocket science that we're talking about here today. And I think that that's extremely important. The other thing is Department of Public Health, obviously more literature. And make use, obviously, I'm sure you already do, with the health centers throughout Massachusetts. I mean, it's a whole network that's already in place. The other thing I just want to make a comment on, excuse me, are in terms of the pharmaceuticals, that perhaps we should do some sort of a tie that when they come in to this state, that they have to either donate funding or a person or somebody to work in a network where they do work on a virus. And that can be statewide, local, nationally. I don't know, but that's just something that keeps coming up in my head when we're talking about it's not a lucrative deal for people to do that financially in terms of pharmaceuticals.
Thanks, Mary. Did you have your hand up?
Ashley Emerson from Seven Hills Global Outreach in Worcester. We do a lot of work in Sierra Leone, so very special thanks to Dr. Bhadelia for your work there. I'm curious about your experience in Sierra Leone and how the outbreak there may relate to the outbreak in Guinea and Liberia, and also just reflections on the CDC's prediction of it reaching 1.4 million cases.
Thank you for working in Sierra Leone. I mean, it's become a community that's close to my heart now, too. So what we know is that the index case in this case, as you know, was in Guinea, in Gekandu. It was a 2-year-old child. And from there, I think you started seeing outcroppings of single cases in Liberia and Sierra Leone in a few months. By March, I think you're already seeing that. And in Sierra Leone, the index case is thought to be a tribal healer who passed away from the disease, and at her funeral, I think there were exposures and they were carried further out. I'm having a hard time getting a handle on the Sierra Leone epidemic because I think it's shifting, and I think that points to the caution when we say that some areas are getting better. It only takes a few missed cases, to start a new epicenter. And Sierra Leone, Kenema, where I was at, was the epicenter then. Port Loko has now become the new epicenter, and we were not seeing any cases there, And so I think continued vigilance is an important one here. And as Dr. Childs was saying, I think even if Liberia and Guinea are getting better, they're neighbors to Sierra Leone. In terms of your second question, I think this was about CDC and 1.5 million. The thing to note is that they said in that model that you're referring to is like 550,000 to 1.4 million. And that's a huge confidence interval, right? That is a huge range in predictions. And the reason why that range, again, exists is that's when you have uncertainty about the data. That's what that stems from. And I think that we can't predict very accurately what's going to happen because we need more hands in the field and we need better data systems. So I can comment that go ahead. Yeah.
No, finish.
No, that's it. I think we just don't know. There's uncertainty.
I think there are several issues that have really been raised here. One of them is really understanding the data. And you have to know those numbers came from predictions if we did not step up the interventions, which we are hopefully doing. So that was kind of the wide intervals of if we continue along the same path versus what happens if we get more intervention. So it's an astronomically high number. It's a very, very scary number, and I think that's part of the reason why you've seen some of the national and international responses that you have is because people realized how bad it could become. The other one is something we were talking about before this panel session started. One of the problems that we have in these countries is diagnostics. And if you look in these countries where all the cases are centered, they're actually where there are diagnostic centers. Where there are no diagnostic centers, there are no cases, which basically means we have no clue what's going on there. And that's part of what we've got to be able to do, is develop diagnostic tools that allow people to go out into remote areas and monitor things without having a cold chain and PCR machines and electricity and so on.
Just a couple comments about projections. First of all, the CDC estimates, they use an estimate of 2.5 underreported cases which go undiagnosed, underreported for every case. So you're ratcheting up those numbers and probably pretty close to the lower estimates if you take into account the permeability of our surveillance systems. And other models, these, even when I've been guilty of association, do look at control measures aimed at hospital measures, community, and burial, which all have very different risk associations. Probably the highest association with increased number of infected persons per a single case is associated with ritual burial. And so projections have to take into account the heterogeneity of populations and the behaviors that put them at risk. And you can project numbers, and I've seen them if there's 80% tracking and quarantine or placed in isolation, 60% or whatever. And even with those projections, the numbers are fairly staggering. But of course, most of those models were based on data in which we were still seeing an exponential increase in cases, which we aren't seeing now yet.
Just a few more minutes we have, so if there's one or two more questions. Yes, ma'am.
Hi, I'm Julie Richer from Harbor Health Services. One of the panel members mentioned that a new infectious disease comes about every 18 months. And I wondered, is that quicker than it was previously, and why that change would be?
I'm not aware of it being really any different than it has been for the last 30 to 40 years. That's kind of the average over the last 30 to 40 year period. I mean, if you think recently, we've seen H5N1, we've seen MERS, we've seen H7N9, and we've seen Ebola in an area where we've never seen it before. So all of those would count, for example, in coming up with a number like that. I don't, and the other viruses that you see are in new areas. So chikungunya, for example, I was just reading an article. There's now 800,000 people that have been infected this year in the Caribbean alone. That was a virus that was never seen in the Western Hemisphere before 2013. So in a year and a half period, we've got millions, and it will be endemic in the U.S. because it's carried by mosquitoes that we have in this country. So, these types of diseases move around, and they all come from, most of them come from spillover from animal populations. And so I think with climate change, with infringing on natural habitats of animals, we're going to see these at certainly not a decreasing rate for the foreseeable future.
And just to comment on that, these are new infections that we're seeing, and too often we are drawn towards putting a pin in a map with a date on it and saying emergence here. And there's no such thing as emergence. These are ongoing phenomena. Things don't emerge usually once, but you're going to see ongoing emergences of the same agent. So you may have 18 new ones, but look at the agents. Ebola's been identified since 1976, and this is still emerging. So we're not only looking at new agents, but we're looking at those reemergences of pathogens which have been previously identified.
And that's to add to that, the ones that are from human behavior. I mean, our own antibiotic stewardship and a lot of drug-resistant bacteria are a major infectious diseases threat. And then when you're looking at things like measles, the outbreaks that we've seen on the West Coast due to decrease in childhood vaccinations with those things, all of those are emerging infectious diseases in some ways. They're coming back. We had some control over them, and they're reemerging.
Maybe one more question. Yes, sir.
You know, it's been very interesting listening to the conversation about a contact infection and how we can control it. We know that certainly within probably the next couple of decades, we're going to have a highly transmissible pandemic flu with huge death curves, massive social disruption. I look at our preparedness plans. They seem very naive. They stem from the WHO. They don't accommodate for the fact of the chaos that will ensue. How do you think we're going to deal with such a pandemic outbreak?
Well, I don't know. Measles, influenza is another story. As we experience, it's going to be around the globe in 2 weeks. And none of the quarantine measures, none of the strict public health measures which we can institute against something like SARS or even Ebola are going to have any impact on influenza. And just an anecdote, when I was a branch chief at CDC way back when, there are only 2 branches within the National Center for Infectious Diseases which did not get congressional mandates to support our programs. One was my branch, which was viral and rickettsial zoonoses, and the other was influenza. So even in historical times, influenza has been often delegated to a back seat, and there was only the outbreak in Hong Kong of H5N1, which again propelled it, and now, of course, it's its own center, its own universe in its own right. But that just shows you how we frequently don't take preparedness into account, and we're too often reactive, not proactive.
I think just to sort of finish up with that, the tendency to be casual about flu is well known, and the number's a bit controversial now, but 36,000 was the number that we quoted for deaths nationally from influenza every year, and it may be a little higher, maybe a little lower from year to year, but it's a big killer, and we should be, as part of responsible health, promoting flu vaccination, of course, and we should be taking every year flu very seriously. I think because of many of the characteristics of influenza, we should also be cautious about flu, and I was glad to see that at least in 2004, 2005, when H5N1 was emerging, that people started to ramp up pandemic planning. I would agree that we are not nearly where we need to be, and I guess maybe what I'm most afraid of is the lack of confidence in science. That when we do start asking for social distancing, and when we start promoting rapid development of vaccination and testing it, that we don't have the public buy-in that we need to, either, again, infection control measures or development of countermeasures. And I do hope that with all the comments that were made here today, that we will communicate better as a scientific group with the public. We will try and continue to gain trust, and we will develop planning and response mechanisms that will allow us to be more responsive. But certainly if we get anything, along the virulence of something that happened in 1918, we're going to be in a tough spot, and hopefully we'll, by then, if that ever happens, we will continue to be better prepared so we have limited morbidity and mortality.
If you just look at the kinetics, the time it will take to make a vaccine to serve the population in a pandemic of flu will be much too late. No. However, we have the opportunity now to think about these libraries, huge libraries of small molecules that one could make small molecule repositories that could be put in cocktails to control any flu that emerges. So,
at least we're not stuck in the eggs.
Yeah, I've seen, and I can't cite the authors who say that once they receive a flu strain, they can actually have, through making small molecules and mixing them up in various ways, have a potential vaccine in a matter of weeks. At least one of these reports came out of Craig Ventnor's lab. And I don't know the details, but it could certainly would be a revolution in how we produce influenza viruses in real time.
Yeah.
Well, with that, I just want to thank panelists for being here today, giving us a very insightful, thoughtful, very, very good. And to Dr. Bhadelia, safe journey. She leaves tonight, and may God be with you. And you truly are a humanitarian in what you're doing, and we're so proud of who you are and what you're doing, and wish you much success. So with that, I want to thank Boston University again, Michelle Consalvo, Meredith Mooney, the New England Council Healthcare Committee, Laurel Sweeney, our chair, and Joel Viani, David O'Donnell, our staff director. Anyone that's not a member of the New England Council, we may have 1 or 2 memberships left. You can talk to David or myself to learn more about Commissioner Bartlett. I want to thank for being here as well. 2 household items. One, if you park next door in the garage, there's a voucher outside here at the front desk for you, so you won't have to pay to park at all. And the second thing is, if you really want to learn more about the NEIDL, the facility, and the wonderful work that they're doing here, again, the front desk will be more than happy to take your name and provide a tour for you in the very, very near future. It's a great facility, and the work that's being done here is extraordinary, and we're fortunate to have them here in this great city. So with that, I just want to thank all of you for being here today, and again, thank our panelists.